Welcome to the UK Dementia and Palliative Care Conference 2025 podcast, brought to you by Rowcroft Hospice. Recorded at the beautiful Buckfast Abbey Conference Centre in Devon, this series explores the critical role of dementia and palliative care in supporting those living with dementia. Across these episodes, we'll be sharing expert insights, real-life experiences, and innovative approaches to improving care. Thanks for tuning in. Let's get started. Supporting decision-making on goals of care at the end of life. Presented by Professor Kevin Brazil, Professor of Palliative Care at Queen's University Belfast.
Hello everyone. Today, it's both been inspirational and humbling. And we've been in a setting which has really encouraged reflection, and the weather has been absolutely spectacular. And also it's been a pleasure to see you, witness you, and talk with you. So it's been a very good day for me and hopefully for all of you. A little bit about myself. So I sit as a professor of palliative care in the School of Nursing and Midwifery at Queen's University Belfast. Also have an appointment at McGill University in Department of Family Medicine. But I'm not a clinician. I'm a social scientist. And as a social scientist, I'm really dependent on what Zena labeled the curious clinicians. So for me to be effective and responsible and responsive in the work I do, I need to engage and work with the curious clinician. That's what makes it work. In terms of the type of research that I've been involved in over the last X number of years, however long that is what's been described or is described as health services research. And that's really looking at service delivery from effectiveness, efficiency, and equity. And also in the last few years, I've taken an interest in what's called implementation science. That really sort of tries to address the question in terms of, if we know what we're supposed to be doing, why aren't we doing it? So it's it's looking at how do we introduce innovation in practice settings so that it's identifying facilitators, optimal conditions for sustaining itself, as well as the challenges. And I'm going to be sharing with you over the next little while my experience with a particular intervention called the Family Care Decision Support Intervention. My relationship with this intervention probably spans something to the effect of 15 years, and it's an ongoing program of research. During the passage of this presentation, you're going to be hearing me use the expression we, and it really does highlight that this has been a collective endeavor with colleagues, academic colleagues within a university, across universities, across countries, as well as with the practice community, as well as with the sort of the lay community as well. That being family carers, those who are family carers of those living with dementia in care homes. That's what the Family Care Decision Intervention is all about. So over the next few minutes, this is our roadmap. So I'm going to take you in there and I'll take you out successfully. And it's really sort of an introduction of the intervention, identifying what its core components are, really sharing with you the evidence of its effectiveness. This is an evidence-informed intervention. It's from the start to the finish. And it's actually not the finish, it's ongoing, as you'll see in this presentation. Implementation and scaling up, how we sort of developed this intervention in Northern Ireland, and it now it's been implemented across 6 to 7 countries internationally. And then, of course, identifying the challenges and where are we going in the future. So we do know that family carers face significant challenges when making decisions about palliative dementia care for a person living with dementia. These experiences may include uncertainty and lack of preparedness in decision-making. Carers often feel uncertain about how best to meet the needs of their relative, especially if formal discussions or legal arrangements are absent. This uncertainty can be sharpened by the dynamic nature of how care is provided and the progression of dementia. Also, we know that there's a heavy emotional burden on family carers. This burden and this trauma can continue years after the passing of a loved one. We know that as a fact as well. Decision-making can be emotionally challenging, with carers experiencing guilt, distress, ambivalence about their loved one's care at the end of life, accepting death, Determining the level of treatment, palliative versus invasive, can oscillate between acceptance and denial, and we know that. And many of you have been are sort of at the coal face and probably can recognize that from your own experiences. Also is this idea of lack of communication. Poor communication between healthcare providers and family members and among family members can often lead to conflict or misunderstanding about care preferences. This challenge can hinder consensus on care decisions and can be a source of conflicts. Essentially, the bottom line is that family carers need support to navigate the complexities on decision-making on palliative dementia care. And this was actually the gap or the need that the family care decision support intervention was developed. Components of the family care decision support, it's not rocket science. That's the wonderful thing about this type of intervention. It's intuitive, it's simplistic, and presumably easy to implement and sustain in a care environment. We'll see what that's like as we proceed in this presentation. The family care decision support intervention is an educational, structured approach designed to assist family carers in making informed decisions about end-of-life care for individuals living with advanced dementia. It aims to reduce decision uncertainty, improve satisfaction with care, enables active participation in decision-making. It has been tested successfully, as I'll share with you, in nursing home across several countries, showing significant positive results. It consists of three components, which you see on this slide. There is the training of nursing staff in delivering the intervention. Staff are trained to support family carers in decision-making and advanced care planning, promoting effective communication and collaboration. Delivery of a family care conference in the nursing home. This is a structured meeting involving family carers and nursing home staff to develop a personalized advanced care plan for the individual with advanced dementia. And thirdly, the use of the Comfort Care booklet and question prompt list, which is a comprehensive resource provided to family carers offering information on disease progression, clinical issues, care options, helping carers to understand the risks and benefits that they're going to encounter. That's the intervention. So what I'm going to do over the next few slides is really kind of drill down in each one of those particular components. So we see here the training of nursing staff. The goal is to build competency on care planning for families with a focus on communication and facilitation skills to support families. The prerequisite for the person delivering the intervention is a registered nurse. We had a lot of back and forth on that. When we initially developed this intervention, we thought this should be available for healthcare assistants to provide as well, and also allied health professionals such as social workers, et cetera. But we were actually, this development of this intervention was actually constrained, if you will, within a research project. It was actually the Ethics Review Board who had concerns that a non-registered nurse delivering this intervention. So despite the desire of the architects of the intervention to have a broad sort of skill mix in terms of providing it, the Ethics Review Board kind of pressed us to have a registered nurse in the delivery of this intervention. And perhaps they were right. And the notion being that the training which we offered the individual providing the intervention really builds on top of this already existing training they have, as well as lived experience. So maybe there's a point there. The actual intervention itself went through two different iterations. The first iteration, which was pre-COVID, is that the intervention consisted of what we called the external facilitator. This was a nurse who was trained in the delivery of the intervention external to the nursing home, who would go into the nursing home, conduct these family care conferences with the family members, typically 2 meetings, write up the advanced care plan documentation, liaise with the care home staff, have those records placed within the resident chart, and also communicate through correspondence with the GP. So the GP was aware of these activities as well. That was the first iteration of the model. But we realized that what we wanted to do is also change nursing home culture, and that this was very much a siloed activity and didn't fully engage the nursing home staff. So the next generation of this particular model was one where we had the external facilitator, but also the role of the facilitator changed. It was actually training and supporting internal facilitators within the home. These were individuals who volunteered and were identified, and also agreed or consented to participate in the delivery of the interventions and registered nursing staff within the home. So we still had the external facilitator in a facilitating, supporting role, but the intervention in the second generation of the intervention was one where the nurse in the home would deliver the intervention. The belief being that this would have sort of a diffusion effect within the nursing home environment around this whole notion of advanced care planning, communication, and establishing goals of care at the end of life. And that's how the present model sort of operates over the last X number, let's say 5 years. The methods which we've used in training, there was pre-COVID approach where we had sort of face-to-face training with the external facilitators. There was, during COVID, everything was turned over, as we all know. We went, as we've heard throughout this day, people reverting to digital methods in terms of delivering. We were dropping tablets in the nursing homes so that we could have conversations online with these staff to provide sort of training, live training through digital technology. Sometimes, if you remember, the nursing homes would open up. There'd be these little windows of opportunity where you can engage with the nursing home, and we get in there and try to have face-to-face encounters. So it was a bit of a hybrid in terms of online sort of training sessions, hybrid interactive online sessions, and if the occasion sort of permitted itself, face-to-face encounters. Just whatever, I think there was something to the effect that was 16 hours of training that the internal facilitators had, and I think for the external facilitators, equivalent to about 20 hours with the online training resources. That said, recognizing the diversity of training options that we sort of implemented, really shaped by the context which we were in, the content was the same. That being, as you can see in this slide, a review of the comfort care booklet, the question prompt list, how to organize and conduct a family care conference, and also documenting the outcomes of that exercise, and eventually this notion of reflective practice as well. Second piece to this component, which you saw on the slide, is this idea of the family care conference. So in actual fact, it was, once again, an evidence-informed sort of approach to conducting a family care conference, and they had, which was shaped by Peter Hudson, who's based in Australia. It was, which was sort of built on a sort of clinical practice guidelines on how a family care conference should be conducted. And it really sort of, if I can sort of, three key components which the staff were trained on. A, how to prepare for a family care conference, which would include a chart review. Prior to the meeting, providing the family members who would be attending the family care conference a copy of the comfort care booklet, making sure they had that beforehand so they could read, review, prepare themselves to ask questions when we met. Securing a meeting room, having the relevant documentation available in that meeting notebook. This is not, again, not rocket science, but it's like a checklist to ensure that there's quality within that family care conference, that there's a consistency and a standardization in terms of procedures, but recognize there's a human touch to it as well. So the second piece would be how conducting the family care conference, that being determining with the family the purpose of the meeting, determining what the family already knows, discussing the comfort care booklet, and also signposting to further services if required or needed, and of course, concluding the meeting, identifying the next steps as necessary, which could be another meeting further down the road. In fact, as part of the training, we did encourage the internal facilitators to contact the family members several days after the meeting just to check in. How's it going? Do you have any questions, any thoughts, etc.? Because quite often, as we all know, you've been in those meetings, and it isn't until you've left the room that those questions pop in. And of course, there's documentation and follow-up. And this is who was present, decisions made, follow-up plans, liaising with the family, as I already described to you, after the meeting, and also this notion of reflective practice as well. So that's the Family Care Conference. And you'll recognize it as what we should be doing, but there is this it's not necessarily what we do in practice. So the idea of actually sort of educating individuals about how to do a family conference and being prescriptive in terms of the stages can be very important for something which we take for granted. It's called the normalization of deviance. And the Comfort Care booklet. So the aim of the booklet is to provide family carers with information that they can better understand the risks and benefit of care option, provide family carers with the opportunity to actively participate in decision-making. It provides information on the trajectory of the disease, clinical issues, decision-making process, and symptom management. The booklet itself is approximately 30 pages, and the UK version is approximately 30 pages, and I'll walk you through it shortly. So dementia progression, clinical issues, decision-making process, symptom management, end-of-life care issues, the dying process, after death, which includes explanation of steps following death, including confirmation of death, body preparation, and liaising with funeral directors. This is the type of content that is included in the Comfort Care booklet. In other countries, like in Canada, where assisted dying is legalized, they had a component around assisted dying as well, etc. So there was variation in terms of the content in the booklet based on sort of country specifics. The booklet did not appear out of thin air. It was originally developed in 2005 by a colleague, Marcel Arcand, an MD with a partner of his, Chantal Caron, at Sherbrooke University, I believe, Department of Family Medicine. And he developed this booklet, and it was subsequently developed or distributed by the Quebec Ministry of Health. So that was sort of the genesis of the booklet. Subsequent to its development, it had been translated and adapted for the Netherlands, Jenny van der Steen, who Wilco knows, Italy, Japan, and of course, English Canada. And those translations, and I was involved in some of that work, we also tested in terms of acceptability, both in terms of family carers as well as service providers as well, with the outcome that internationally in those various jurisdictions, high levels of acceptability and also showing impact on knowledge and attitudes. So there was something positive about the booklet. It had also, back in 2011, had been recognized by the World Health Organization as a best practice document in geriatric palliative care. So that's sort of the history of the development of the booklet. Of course, there's a contextualization process which we engaged in at the country level in the UK. So, for example, with the version which we have here in the UK, we actually had it reviewed by healthcare professionals, both in terms of palliative care physicians, nurses, dementia nurses, palliative care nurses, as well as service users as well, to sort of look at its acceptability. What we're going to go back here is, so this is actually the Comfort Care booklet itself. And so if you were here in the UK, as you can say, this is the United Kingdom version, and these are the various chapters of this booklet of approximately 30 pages. It's interesting, even the imagery through sort of co-design or PPI, we have the images, the users identified that, I think the original version that was developed by Marcel had images of individuals, the classic, the holding of hands. We've seen some of those images here today. But the potential users didn't want that. They preferred sort of, as you see here, flowers, pastoral shots, and so on. So it's just interesting in terms of some of the assumptions you have about preference as opposed to what you actually hear itself. But this here is the Comfort Care booklet. One of the things that we did develop in our transnational study, and Jenny Vandersteen was instrumental in this piece, and Wilco, I think you may have been involved in this as well. And that Wilco was involved in the transnational piece, and is we developed a question prompt list. And the question prompt list is really, its aim is to enhance information provision, encourage active participation with the anticipated impact of making information more personally relevant, improving psychological or emotional outcomes, as well as increasing knowledge gains. So as I described earlier with respect to the process, prior to the Family Care Conference, the intent is to share this booklet prior to the meeting. So the family members not only would have an opportunity to review the contents of the booklet, but also the question prompt list enabled them to either resort to these questions or triggered new questions that they could bring to the session as well. So it was a key piece of work. And in terms of developing there were two groups involved in this, colleagues in Leiden and a group of us in Queen's University Belfast. We identified 3 booklets, dementia care booklets, from Australia, Canada, and the Netherlands. It provided us with a pool of about 248 items. And from there, we screened for relevance, prioritized, and then selected in terms of placing in the booklet. And the reference for this is actually, the citation for the work is actually there with Laura Bevlar, who was a PhD doctoral student at the time, in terms of a feather in her hat in terms of leading the manuscript, in terms of publishing it. So good for Laura. One of the things I didn't do in this presentation, which I will provide to the organizers, is a list of the publications that went into the development of the innovation which I'm sharing with you today, so then you can sort of resort to, you can take a look at the references, then you can critically appraise it on your own merit. So what does the question prompt list do? What's the interface? Well, what we have here, so this is what it would look like if you're a user. You receive this particular booklet. So this is one section here in terms of the natural evolution of dementia. And preceding it, the questions were embedded within the booklet. So these were some of the questions that were inserted. So can you tell me more about palliative care and dementia? What do you want to know about my relative? So you can provide appropriate and quality of care. What are the advantages and disadvantages of resuscitation? My relative has dementia, but also other medical conditions. So you can anticipate, perhaps you recognize some of the questions from your own practice that you've heard from family members, or you wished family members were asking you and you had to provide them those questions. Here's another example. Decisions, questions to consider. How can I make arrangements to meet the doctor? Not as easy as it may sound. What spiritual or religious care is available to us? Is it possible for me to see someone else if I don't get along with the nurse or doctor? How do I go about this? And we know this scenario. I hear it, I have a mother-in-law in her 80s, and there's always an issue in terms of the care staff. Do they get along? There's tension between. In fact, they say that the greatest source for care home staff in nursing home is actually between family members and the staff. It seems to be the greatest source of stress for care home staff. So it's not unusual for dissatisfaction, conflict to exist within that dyad or dynamic. And then, can you arrange for me to talk with someone from my own culture and someone who may understand me better? So we live in a multicultural society, and we need to sort of engage and incorporate that within our work as well. And that's an example of that. Moving along, and I think we're doing fine. Well, I have a 5-minute sign-in when it comes, but I think we're doing okay. So what I've just done is I've given an overview of an intervention, which in my view is fairly straightforward. As I've said a couple of times already, it's not rocket science, and we do it. Many people say we do this already. In fact, I heard that from one particular nursing home. This is great. We do this already. But the question is, do you really? And this is this notion of normalization of deviance. And to what extent are these processes, I remember on one occasion with my own mother in a nursing home, sitting down with the the nurse, and she was doing a general sort of intake assessment of my mother. And it went through in about 5 minutes, and I said, oh my God, I think she was doing an advanced care plan with me, and I didn't even realize it until after the fact. So, she probably considered it a family care conference. She documented the material and walked out, but I had no idea, and I'm somebody who's involved in care home research and advanced care planning. It wasn't until after the fact that I thought, oh my God, that was an advanced care plan we were completing. So, I think these types of interventions are really important so that we are consistent in how we deliver it. So I think it's the idea you have in terms of service provision. We all recognize those pockets of excellence, and it could reside with a particular provider, a particular institution, or within a particular region where there's an excellent sort of outreach team. And the goal is, how do we standardize that excellence across the system, or across providers, or across institutions? So when you create an intervention like that, I think that's what we're trying to do, is standardize the quality of provision so that everybody has an opportunity for quality care. So here we are, evidence of effectiveness. And so I open this presentation sort of advising you that this is a long story. This is my story in terms of my relationship to this particular intervention. And the first study we did, although the Comfort Care booklet was developed in 2005, I think what the slide said, and there were a number of sort of descriptive studies that were done. In 2000, we developed in 2013, thereabouts, I sort of developed this intervention called the Family Care Decision Support Intervention, and we ran what was called a clustered randomized control trial. It was conducted in Northern Ireland. It consists of 24 homes, 12 intervention, 12 usual care. And the outcome was, as you can see here, we have a copy of the paper there. And colleagues, some of you may recognize some of those names, perhaps not. And but yes, it does highlight sort of a team approach in all these. It's not only in terms of care, but in research. It's the microsystems of care is teamwork, and sort of systems of research. Research is all about teamwork and interdisciplinary functioning. And so this was published, I think, in 2000 something or other. But what we found was that the outcome of that intervention was improved perception of satisfaction around nursing home care, and the reduction of decision uncertainty around making decisions around goals of care. And just before I came on here, I scratched down some notes. We used something called the Decisional Conflict Scale, which was designed to measure personal perceptions of uncertainty and conflict when making decisions. So that's how we held this intervention accountable. So what we can say is that this intervention offered values for the user, values clarity, it reduced uncertainty, it informed them, and they felt that they received the support they needed, and they made effective decisions. So that's using the decisional conflict, measuring those particular domains, that's what this intervention was provided to these individuals. So that study ended in 2016, and subsequent to that, we were working in Northern Ireland. We were sort of promoting it for uptake with the policy practice community with some success. But, it's hard work getting some of this innovative work into the practice environment. And I don't want to go into discussion about the academy, but so we'll continue. That said, we were successful in terms of obtaining funding from the EU Joint Program Neurodegenerative Disease Research. You can see why I need notes, as well as the UK Alzheimer's Society. This was a scaling up implementation study. So we knew this intervention was effective, but what we wanted to do is scale it out and trial it in different settings. And so the countries involved include, in Canada, it was in French English Canada, and it was in the Republic of Ireland, down in the Cork region. In the UK, it was both in Northern Ireland, but we scaled it out into England itself, up into the Lancaster area and the Leicester area. It was also conducted in the Netherlands, and Wilco was involved in that with Jenny van der Steen. It was Prague, the Czech Republic, and ultimately in Italy, in the Turin area, I believe. So we sort of went from that little tiny study in Northern Ireland, and opportunities to sort of allowed us to sort of roll it out internationally. But what we did as part of that study is we looked at conditions relevant to implementation in terms of what's optimal with respect to implementing this type of intervention within the nursing homes. And these, you can see here, some of the conditions you need for successful implementation. Trusting and supportive relationships between all stakeholders, that being with staff, between staff and family members, and also recognizing that trust is dynamic and is earned, The other thing is that it had to be perceived by the staff and family members that address family priorities. This is actually based, we conducted 289 interviews across those 6 countries, and we did a qualitative analysis, quite intense. We published it in the Gerontologist in 2024, and this is some of the outcomes. So it was a large qualitative data set. It was quite amazing. And then we needed committed, engaged leadership. Leadership is really important. And also there's a nursing home cultural element, a culture where there was a readiness and openness to change. These were innovative environments. They were interested in change. They wanted to improve their practice. And nursing home staff felt capable and comfortable engaging in families' discussions. The whole idea of training staff to be on communication and feel comfortable with that, very important. Resource impact was a big issue in terms of how did nursing staff incorporate this within the nursing home environment. It was a challenge, but they did come up with suggestions on how to do that. And with respect to training more staff, what else did they say here? More staff was seen as important. Integrating the intervention into usual care and recognizing what processes are already transpiring within the nursing home where this could be integrated was important as well. So yes, it was challenging in terms of integrating this in the home. However, they also came up with the suggestions in terms of how it could be integrated into the nursing home environment. So once again, it's this notion in terms of implementation science where, when you're introducing innovation, is this notion of adaptation. You have to be prepared to adapt your innovation to suit the context of practice. And that calls for a real engagement with the providers. I have 2 minutes. I thought I was going to end quite early. I'm going to skip over this. Oops, maybe I should. These are just quotable quotes, but I think the slide deck I think will be available to you at another point in time, so we'll skip over this. And this is, if I was challenged to fill time, I would have drawn out a bit with these particular slides, but given the situation we're in, I'm going to skip over them. But anyways, they're all wonderful quotes, so there you have it. But where are we going now? We created this particular piece, it's online, so it talks about the first element here, it's Comfort Care Guide, Comfort Care Booklet and Overview. You can see the website up on the top. 2, Family Care Conference, how to access, how to use it. Unit 3, communication. We actually sort of emphasize the remap here. And it's a mixture of text and videos and a little quiz on each unit. Unit 4 is reflective practice, which you heard me speak to. And then finally, in the last piece, you can actually download the booklet as a PDF, and I have 1 minute. And where are we going from here? One time I was red carded, and they threw me out. But so we have received additional funding from the Horizon. It's a 5-year project where we are now taking the decision support interventioning, and we're yoking it with Namaste, wherein we're providing real-time care as well as future care. It's a 5-year program of research. We're 1 year into it. And those of you who may have attended the Namaste session know what that's about. I won't go into a lot of detail. So we're all and this is going to be sort of implemented across 7 European countries, and we're now looking to sort of ramp it up in Canada as well. So that is my story. These are some of the sort of key points targeted focus, structured approach, adaptation, comprehensive training, measurable outcomes. I think I'm done. Thank you very much. Thank you.
That's it for this episode of the UK Dementia and Palliative Care Conference 2025 podcast. A huge thank you to our sponsors, Majestic Holidays, Wallens, Amica Care, MC Hearing and Audley, and to Dementia UK for their invaluable support. This series is recorded and produced by iNarrator and proudly hosted by Rowcroft Hospice. Links to resources mentioned are available in the show notes. If you found this discussion valuable, please share it and stay tuned for more thought-provoking conversations. Until next time, take care.